Good morning to all of you all. We are going to talk about tuberculosis, what is new. There's a lot of things that are happening in TB. The diagnosis is changing, the treatment is changing, there are new drugs that are available. If you look at childhood TB, 10% of the total TB burden in the world is in children. Childhood TB is often underdiagnosed and underreported, and there are advances in diagnostics and medicines that have led to the changes in TB treatment. So let's go on to diagnosis of TB. What is new? Till now, we only had, in children, we often used to use Tuberculin skin test to make a diagnosis of latent TB and sometimes even active TB. We used to use PPDS, that is your purified protein derivative, standardized, which is equivalent to 2 TU of RT23 twin 80. The standard PPDS that we are supposed to use is 5 TU. Twin 80 is a detergent that is added to the PPD so that it does not stick to the glass syringe. So current recommendation is either you use a 2 TU PPD RT23 or a 5 TU PPDS, and you take a cutoff of 10 millimeter as positive. The problem with tuberculin skin test is it also becomes positive when you are infected with environmental mycobacteria or BCG. So it does not tell you infection by MTB alone. CTB test is a new generation skin test. It's similar to your tuberculin skin test except that the antigen is different. It's an ESAT6 and CFP10 antigen, which is unique for Mycobacterium tuberculosis. So it's not affected by the BCG vaccine. So in future, this test is going to replace your MAN2 test, and an induration of 5 millimeter is suggestive of MTB infection. Antigens that we are using which are very specific for MTB. So this test, if it's positive, it tells you infection by MTB and it is not by BCG or by environmental mycobacteria. This test currently is not available in India. So we are not able to use this test, but it is available abroad and apparently the results are very, very good. So MAN2 has its own problem. We've been using Interferon-gamma release assays. Now Interferon-gamma release assays, the next slide, have Quantiferon TB gold as well as the T-spot. Now till now we were using Quantiferon TB gold. It uses the same antigens that I told you earlier for CTB net, that is your ESAT and CFP10. There is a new generation Quantiferon TB gold that is known as Gold Plus, where it also looks for response of CD4 and CD8 to these specific antigens. So the sensitivity has improved. If you look at MAN2, the sensitivity is around 60 to 70%, specificities are also around the same. The Quantiferon TB gold also gave us a sensitivity of 60 to 70% with a specificity of the same. But with this gold plus, the manufacturer claims that the sensitivity is 94% and it's almost specificity of 97%. And it also can be used in children up to the age of 2 years. Quantiferon TB gold used to give us a false negative results in children less than 5 years. But now with the gold plus, you can get it up to 2 years. So this is supposed to be a more effective test currently available. And we are doing a trial right now of this latent TB with this Quantiferon TB gold and looking at incidence of latent TB in these children. Next slide. So if we look at a comparison of skin test, PPD, the CTB and the Quantiferon TB gold, specificity very good with CTB, very good with Quantiferon TB gold plus, but poor with tuberculin skin test. Sensitivity is high of all of this, so you could have a lot of false positive MAN2, which means that the child is actually not having TB. Cost of test wise, MAN2 is very cheap, Quantiferon TB gold is expensive. You need a lab, you need to do a blood collection in these children, and Quantiferon TB gold is affected by children's age, so less than 2 years you may get a false negative. MAN2, younger age, you may get a false positive because of MAN2 because of BCG. So you have these pros and cons of various tests. I'm just going to share our experience when we did a MAN2 and IGRA in patients suspected with TB. We had totally 33 patients in this particular study. MAN2 was positive in 24, so a sensitivity of 72%. Quantiferon was positive in 15 only. Now what happened, why was it positive only in 15? Because a lot of it was false positive MAN2. These children didn't actually have TB. And if you look, when we took up MAN2 cutoff of 10 millimeter, if we look at the positive predictive of MON2 was only 42.4%, whereas when we took a TST of positive of 15 millimeter, a positive predictive value increased. So how did this quantiferon TB Gold help us? It helped us to rule out false positive MON2 test. Next slide. So most important is when we are using this MON2 and IGRAs, you have to be very careful how you interpret these reports in a clinical scenario. We look at latent TB. Latent TB, till now we used to say that latent TB is based on evidence of TB bacilli in your system and there is no evidence of any clinical disease. WHO has now modified this definition. It says a state of persistent immune response to stimulation by MTB antigens with no evidence of clinically manifest disease. So latent TB means you must have an immune response. This can be determined either by a MON2 or an IGRA. And now WHO recommends you can use either of the tests. So it's not only MON2 to determine latent TB, now you could use IGRA also. So this is the new update in diagnosis of latent TB. Again, who should receive prophylaxis for latent TB? We used to have an earlier guideline. We used to say that all children less than 5 years who are in contact with TB should receive prophylaxis for latent TB. HIV positive patients, whether they have a positive MON2 or negative, everybody should, whether they are on ART or not, they should receive prophylaxis. The new update in the guideline is that in older children who are more than 5 years, adults, adolescents who are in contact with a household having bacteriologically confirmed TB, then you should put them on prophylaxis. So this is a new update. So now you should screen everybody in the family, not only children less than 5 years, you screen everybody in the family. And anybody who's got a positive MON2 or positive IGRA, you need to put them on prophylaxis. Again, patients who are going to go on anti-TNF treatment, patients on dialysis, patients requiring a transplant, you should put them on latent TB if they are positive for MON2 or IGRA. So that's the new update. And treatment wise also for latent TB, next slide, we used to give 6 months of INH. Now WHO also recommends that you can give INH rifampicin for 3 months. And people who don't like to take daily, you can do an observed therapy by giving rifampicin and isoniazid weekly for 3 months. So 12 times they have to come to the clinic and take the medicine in front of you. So this is something which even the program, RNTCP program, is thinking of putting it into the program of using rifampicin and isoniazid. And next slide, these are the doses that we use in children and adults. INH in children is 10 mg per kg for 6 months, maximum dose is 300 mg. When you're using INH and rifampicin, INH again is 10 mg per kg, rifampicin goes up to 15 mg per kg. And when we are using weekly rifampicin, the weekly rifampicin is weight based, so there are these weight charts that you need to keep. And INH actually goes to 25 mg per kg. So in children who are 2 to 11 years and more than 12 years, you give 15 mg per kg. Because it's weekly, you give this particular dose. So this is about the treatment of latent TB. What about MDR? Till now, WHO had recommended that patients who are in contact with MDR TB, you keep a close watch but don't start them on prophylaxis. Now they say that in selected high-risk household contacts, who are these high-risk? Children, people receiving immunosuppressive therapy, or those who are HIV. These patients, if they come in contact with an MDR TB patient, somebody in the house, then that household contact should receive prophylaxis based on the DST of the index case. Now, what are the drugs that are recommended? Ideally, a fluoroquinolone, that's like your levoflox or moxiflox. Unless that strain is resistant to them, then you use other drugs. Sometimes we use pyrazinamide, sometimes etambutol, depending on what the DST pattern is. So now this update, in selected high-risk household contacts, you could put them on prophylaxis based on the DST pattern of the index case. This was about latent TB. Now let's go about molecular bacteriological diagnosis of TB. Currently, what we use in the country extremely well is Genexpert. You have other types of molecular tests, that is your LIPA, which we hardly use in this country, but we have this NTB-DR+, that is the LPA, line probe assay by Hain, that we are using, and I'll come to that later on. If you look at Genexpert by the manufacturer is recommended only for pulmonary TB, but we have been using it in extrapulmonary TB samples as well. In our experience, we tried it in 34 patients. This is about accuracy in Genexpert, how well it is with MJIT. And next slide, you can see this table. In this table, we find that Genexpert was positive in 20, that is 58%. And MTB was positive in 19 out of 30, that is 63%. So Genexpert was quite effective in picking up. The only problem that we faced is sometimes we used to have Genexpert which showed no rifampicin resistance, but on DST, conventional DST, they were found to have pre-XDR. So Genexpert always is not going to be foolproof. So if you have a very low bacteriological load, sometimes it may not pick up rifampicin resistance. So be careful. So don't rely only on Genexpert. You have to send your conventional bacteriological cultures as well. Regarding extrapulmonary TB, we've used Genexpert with the culture, and you can see both are almost equivalent. Both pick up pretty well. So Genexpert can be used for extrapulmonary TB as well, though the manufacturer's label still says pulmonary TB. If you look at this, Genexpert in pulmonary TB, our data again very good. Sensitivity and specificity of Genexpert when compared with MJIT was 86% to 68%, and a kappa coefficient of correlation of 0.55, which tells you it's very good correlation. So it really works very well in pulmonary TB in children. The new update in Genexpert had a capacity of detecting 131 bacilli per ml of sputum. So it would not detect if the bacterial load was less than 131, and then the test would come negative. Now you have new cartridges that are available, which is known as Genexpert Ultra, which can detect 16 bacilli. So it can even detect lower number of bacillary load. So it's very good for diagnosing paucibacillary disease. Genexpert Ultra is now available in the country. We have been using it in our hospital. Through the RNTCP, we still get the plain Genexpert because they have a lot of cartridges still. Once that cartridges get exhausted, even in RNTCP, you will start getting a Genexpert Ultra, which will give you a higher yield as compared to the regular conventional Genexpert. Now this Genexpert is a test which is manufactured abroad, so it's extremely expensive. With the Make in India, we have other nucleic acid amplification test, the TruNat, which has been developed in India. It is still pending WHO approval. It's similar to Genexpert. It looks for rifampicin resistance, molecular test. Advantage, it's battery operated, so even if the electricity goes, you could still keep on running this test. The only problem, Genexpert was fully automated, whereas here this test is not automated. It requires a DNA extraction technique, so you need a technician who is well versed to operate this particular test. But once this test comes out in the market, we will have really cheaper results coming out. Now I come to the line probe assay, the Hain test which I told you. Genexpert was only able to pick up rifampicin resistance. This line probe assay is able to look at additional resistance. So you have two types of line probe assays. One is MTB DR plus, which looks at INH and rifampicin, and you have MTB DR SL, that's your second line, which looks at fluoroquinolones and second line injectables, so your amikacin, capreomycin, kanamycin. Advantage, your conventional DST, you looked at culture for 3 weeks, doesn't grow, wait till 6 weeks, grows, then you do a DST another 3 weeks, so by the time you get a report, it's 9 weeks. LPA gives you a report in 24 to 48 hours, and you can do it in any sample. You don't need to wait for a culture positive, you can do it in a smear positive sample. So you can decide whether this patient is XDR TB, MDR TB, and devise your regimen immediately within 24 to 48 hours. So line probe assay is highly used in the RNTCP program. Next slide. You have newer tests. You have something like a pyrosequencing, which can look at additional resistance. So pyrosequencing is a DNA sequencing where it looks for detection of pyrophosphate, which is released during DNA synthesis. And the additional resistance, it looks at rifampicin resistance, INH, ethambutol, streptomycin, amikacin, and it can produce a result within 6 hours. So you get these genetic mutations within 6 hours. This particular facility is not available in all the labs. and it's extremely expensive. So you have to decide which patients you actually want to do pyrosequencing. So we come to this particular chart which is there in your RNTCP program. So you have all patients whom you picked up Genexpert positive. You picked up rifampicin resistance. The next thing that you're supposed to do is a line probe assay for the second line. If it is fluoroquinolone and second line sensitive, then you can treat this patient as just a plain simple MDR with a shorter MDR regimen. If it is fluoroquinolone or a second line injectable resistance, then you may have to devise a regimen for a pre-XDR or an XDR TB. If your CBNAT shows rifampicin sensitive, you still do an line probe assay, but you do for the first line because you want to look at mono resistance to INH. If it is mono resistance to INH, you treat the patient for mono resistance, H resistance. If it is H sensitive, you know this is drug sensitive TB, just continue with your first line drugs. So this is how the program looks at it. First they do a Genexpert, and then depending on the Genexpert, if it's RR, you do second line LPA. If it's rifampicin sensitive, you do the first line LPA. Lot of advances also in treatment of TB. We used to earlier have lot of categories of TB treatment where you used to use 3 drugs in the intensive phase, and then you used to use 2 drugs in the intensive phase. Some TB we used to use 4 drugs in intensive phase, and then now everything is standardized. Every patient who's newly diagnosed TB, irrespective of whatever kind of TB, any patient who is getting TB for the second time, also while you're pending the DST reports or the Genexpert reports, you can put the patient on 2 months of intensive phase of HRZE and 4 months of continuation phase of HRE. So even your category 2, which was there earlier, treatment failure, where you used to give 2 months of HRZES, is out because streptomycin has got a lot of resistance in India. So it's straight away 2 months of HRZE and 4 months of HRE. Very simplified guideline. The drug doses, you need to remember the drug doses. Rifampicin, ideally 15 mg per kg per day. INH 10 mg per kg per day. Pyrosequencing 35 mg per kg per day. Ethambutol is 20 mg per kg per day. And streptomycin is 20 mg. So the doses have changed. So please remember these new doses. And what we do, next slide, you have these kind of charts that we actually keep in the OPD. You have these now fixed drug combinations that are available through the program. So you, among your pediatric FDCs, the fixed drug combination, you have INH, rifampicin, pyrosequencing available as one tablet and ethambutol as a separate tablet. So you have these weight bands. Depending on the weight bands, you can give the FDC, the dose. So if you have a 4 to 7 kilo child, you give 1 tablet of HRZ and 1 tablet of E in the intensive phase, and continuation phase is 1 tablet of HR and ethambutol 1 tablet. So you have these fixed drug combinations. I have this chart which is pasted on my table. So every time I need to refer, I have this chart with me where I refer the patient and decide on the dosing. Now, how do we diagnose pediatric pulmonary TB? So this is an important chart, and I'm going to spend some time. Whenever you have a patient who has fever for more than 2 weeks, cough more than 2 weeks, weight loss, and contact with or without a contact with pulmonary TB. So you're suspecting clinically TB in this patient. The first thing that you're supposed to do is a chest X-ray. Once you've done a chest X-ray, if it is highly suggestive, what do we mean by highly suggestive? Miliary TB, fibrocavitary TB, those kind of TB, highly suggestive. You do a sputum, you do a gastric lavage, or you do an induced sputum and send it for Genexpert. If the Genexpert is positive, it is definitely TB, and you treat the patient for TB. And the first chart that I showed you, whether it's RR or RS, you have to decide and then treat accordingly, drug resistant or drug sensitive TB. If your Genexpert is negative, then you look for extrapulmonary symptoms. So you look at whether there is a gland palpable, whether there is an abdominal TB, whatever. If you find a gland, then you repeat the CBNAT from the gland. If you are sure this is pulmonary TB, then you may try to get a BAL, or you may take a second opinion. If the X-ray is showing non-specific shadow, it's just a pneumonia kind of a shadow, you give a course of an antibiotic. If the antibiotic has already been given, skip this step. If it still shows persistent shadows and symptoms, you have to get Genexpert done. So if it's non-specific shadows like a pneumonia, first give an antibiotic, repeat an X-ray. If it improves, nothing to do. If it doesn't, then you do a Genexpert. And if that Genexpert is positive, then you are going to treat it as microbiologically confirmed TB. HIV has to be done in all patients with TB. So make sure that anybody who is diagnosed as TB, you have to do an HIV test. If you didn't find anything, then again you have to refer to a higher center. If that X-ray test is normal and you still have this patient who has signs and symptoms suggestive of TB, look for extrapulmonary TB. So is this chart very clear to the audience? I've tried to make it as simple, and this is the chart now which will come through the program in IAP as well. So this is the new chart in the new module. Pyridoxine. Now regarding pyridoxine, earlier we never used to give pyridoxine in children. Now it is recommended that you have to give it in all children who are on receiving TB treatment, as well as the ones who are receiving INH prophylaxis for latent TB. Dose is 10 mg per day. In case of drug-resistant TB, because you have additional drugs like cycloserine, you have to give 50 to 100 mg per kg per day, not per kg, per day, to prevent pyridoxine deficiency. Drug-resistant TB is a lot of advances are coming up, so I will just give you little definitions of drug-resistant TB. Monoresistance is resistance to one drug. Poly means more than one drug. MDR means resistance to your two main drugs, that's your INH and rifampicin. XDR means INH, rifampicin, quinolone, aminoglycosides. And rifampicin resistance is what we pick up on your Genexpert. And when we get rifampicin resistance, we always assume that INH may be resistance, and it's an indirect evidence that this is an MDR TB patient. So when we have MDR TB resistance, I have already done this particular slide before, where we look at drugs resistance depending on whether it is quinolone, is it MDR, is it pre-XDR, is it XDR, or is it H mono resistance. Next slide. The grouping of the drugs for MDR TB has changed. Earlier we used to have group 1, group 2. So we used to have injectables in group 1, we used to have the quinolones in group 2. Now depending on their efficacy, group A drugs contain either levoflox or moxiflox, bedaquiline in cases of adults, and linezolid. So how do you make this group? You have to use all three. In children we are still not using bedaquiline, so your combination has to have levoflox or moxiflox and a linezolid. Then group B, again try and add both the drugs. So your group B is clofazimine and cycloserine. And group C, to make a regimen of at least 5 drugs, you are adding something from group C, where your ethambutol, delamanid, pyrazinamide comes. All your injectables have now come in group C. So you don't really want to use injectables now in children. So now your combination therapy is going to be levoflox or moxiflox. It's going to be linezolid, clofazimine, cycloserine, and then one from group C. Most of the times we use delamanid. Delamanid is recommended by WHO in children 3 years and above, by RNTCP 6 years and above. And in case you don't want to use delamanid, then what we use are the other drugs like PAS or ethionamide. The new drug that we are using is Delamanid, and Delamanid is available through the program only. It's not available in the private sector. It works by blocking the synthesis of mycolic acids in MTB, and WHO recommends it only currently for pulmonary TB. So it's not available for extrapulmonary TB currently. We have used it for compassionate use in extrapulmonary TB patients as well, as when we found good results in them. The major problem is the cardiac side effect of QT prolongation. So when you're using Delamanid, you really have to monitor these patients. And we have been monitoring these patients quite regularly for hypoalbuminemia, hypokalemia, ECGs for QTC intervals. And most of these patients do well when you're starting these therapy. It's available as a 50 milligram tablet. So children less than 35 kilos, we are giving 50 milligram twice a day. Children more than 35 kilos, we are giving 100 milligram twice a day. Till now we've used Delamanid in almost 25 to 30 children, and we've had extremely good results in these patients. So you have this 217 guideline which had these injectables and very difficult to use. Now you look at the 2019 guideline, it's very simple. You have Delamanid, levofloxacin, linezolid, clofazimine, cycloserine, 6 to 8 months, followed by 12 months of the remaining drugs. Bedaquiline has been approved in children up to 6 years, but not yet available in India for children. It's only for adults. There is new evidence now available that you could use a shorter regimen for MDR TB patients. So it's going to be an oral therapy without an injectable. So new evidence is coming up for that. New evidence is coming up for using Bedaquiline and Delamanid together in MDR TB patients. There's a new drug, Pyridoxine, which has been approved by US FDA last week, and there is a combination of Bedaquiline, Pyridoxine and linezolid for using in patients with MDR TB. So we have a lot of new evidence and a lot of new guidelines will keep on getting updated. So that's my last slide. Next slide. That diagnostics and newer drugs are continuously available in treatment of TB. The guidelines are constantly evolving. TB elimination is a goal. And latent TB, active surveillance in children, is something that we are looking at if we really want to look at TB elimination. Next slide. Thank you very much, and that's my team in the TB clinic, and thank you very much for your support.